Okay, everyone, welcome to another session of the Collaborative Learning Meeting at WPI. We got a guest today, Nasser, who's going to be presenting his work on Lyme disease. He's a PhD candidate in System Science and Industrial Engineering Department at Brigham University, and his concentrations in health systems. He's involved with several system dynamics modeling efforts. They're transdisciplinary, and he's collaborated with a team of anthropologists, nurses, engineers, and primary care providers to develop models for public health issues as Lyme disease, Ebola, and access to care and HPV infection. I think today he's going to talk to us about Lyme disease, so I'll go ahead and hand it over to Nasser. Switch over.
Can you maybe a word about when the questions should come?
Oh yeah, so today, because we're going to get to the material, he's got two breaks, a break in the middle after his first section. So if you can hold your questions for that first break, and then we'll go ahead and have a brief Q&A period, and then we'll begin with the second section. Thank you.
So thank you for the introduction and the opportunity. My name is Nasser, and I'm going to talk about my dissertation, which is proposing population health interventions to alleviate the burden of health issues, including infectious diseases. And I have used system dynamics methodology with GIS mapping in order to do that.
And real quick, I hear microphones are still on. If you're online and coming online, please mute your microphones. Thank you.
So why health system research? The burden of health issues and the associated costs of population-level health problems are significant, and they require a considerable amount of prevention efforts and involvement of different stakeholders. So as an engineer, I wanted to try to model these complex systems and propose interventions that can alleviate the burden of those health problems. So when you look at population health problems, it mainly consists of two different things: determinants of health and people and medical community. So determinants of health consist of 5 different categories. We have social and environmental factors, we have health services, biology and genetics, and 2 other things. And also, the very important things are medical community awareness and community awareness. So far in my dissertation, I have looked at medical community awareness and community awareness. I have looked at policy making, social and environmental factors, and accessibility. For my future work, I would definitely look at the other factors if I get the data for them. So my dissertation consists of 3 different essays. In the first and the second one, I have developed system dynamic simulation models for Lyme disease and HPV infection. I have looked at policies, environmental factors, human factors, and access to care. In the third one, I'm combining system dynamics with GIS mapping to study Medicaid access to primary care providers. And I've looked at the spatial factors. So today I want to talk about Lyme disease, which is my first essay of my dissertation, and the paper is under review at Journal of Royal Society of Open Sciences, and we hope we get it published by the end of next month because we just submitted the first revision. I want to acknowledge that we have been working in the past 2 years with Professor Garuto from Anthropology Department, and this is an interdisciplinary research between SSIE, our department, and anthropology. So Lyme disease is among the top 10 infectious diseases and is the most common vector-borne disease in the United States. About 300,000 Americans are diagnosed with Lyme disease every year, and 36% of them develop post-treatment Lyme disease, which entails a huge cost. All these facts made us to look at this complex system and develop a simulation model to propose interventions. So the Lyme disease bacterium, which is called Borrelia burgdorferi, is spread through the bites of infected ticks. Ticks are these small species. As you can see, they are very small, and if they get on your body, you can't see them with your eyes. When they are in the nymph stage or larva stage. When they get bigger, when they get adult, you might see them. You can remove them from your body, but you just have 1 to 2 days before removing them. Otherwise, they would transmit the infection to your body. So Lyme disease causes severe headaches and flu-like symptoms. But if you don't get diagnosed with that, and you develop post-treatment Lyme disease, you get more severe symptoms like arthritis and nerve pain. And most of the people would be recovered completely with antibiotic treatments, but if you get diagnosed, if you don't, that's the worst case scenario. So there's a large variation in the number of cases in each state, and the number of cases are strongly correlated with the number of with the density of infected ticks, and the data for ticks, infected ticks, and rodents population and behavioral, human behavior and environmental risks were available for Binghamton University campus. So that's why we have focused on the campus as the scope of our simulation model. Our goals are to illustrate the factors that are driving the high number of Lyme disease cases, and we are showing the interaction among those factors within the causal loop diagram. We want to propose the interventions that can alleviate the influence of those factors, and finally, we want to develop a framework that can be accessed by public to assess the Lyme disease risk in their region. So I know that all of you know about system dynamics. I'm going to skip this part, but my goal, just to mention that, is that I want to bridge the gap between industrial engineering and public health, because I want to propose policies and interventions that are applicable from public health perspective. So this one shows the number of LD cases in Broome County, where Binghamton University is located. As you can see, the number of cases has been increasing in the last decade, and it starts from 2000 to 2015, and in 2015 we get almost 203 LD cases. This one is a causal loop diagram. Shows the causal loop diagram of Lyme disease, which is something that is very important, is that we have 6 different loops here. The most important one is the production of ticks. So ticks are adults, they lay eggs. When the ticks come out of the eggs, they become larvae, which are very small. Then they become nymph and they become adults. This shows just the reproduction of ticks. In between, some of the ticks become infected if they get blood from infected rodents, from infected mice. So we have the feedback loop here that animals get infected from ticks, and sometimes ticks get infected from animals. And also we have another loop that shows the increase of pathway risk due to the increase of tick density. So in Binghamton University, we have considered 22 different walkways. And in each walkway, we have gathered the data for ticks, rodents, and human risk. So when the number of ticks and infected rodents increases in the walkway, definitely the risk of getting Lyme disease in those walkways increases. Then we have loops for LD treatment. So the number of LD cases increases, the treatment increases if the awareness of medical community increases. And the other one, which is very important in our simulation model, is the awareness of ticks. So when the efforts to increase awareness increases, public awareness increases, and after that, situational awareness increases. By situational awareness, we mean that people start to adjust their behavior by looking at the environment, by seeing how ticks are affecting their lives. So they try to decrease their behavioral risk, such as sitting on the grasses or wearing shorts in the summer and hitting the shrubs. And also they decrease the time length of exposure to those risky environments. So by looking at these 2 graphs and diagram, we hypothesize that LD cases are still increasing due to the forest fragmentation, low situational awareness in public, and increase of infected rodents and ticks. Also, we think that increasing awareness is not enough to prevent Lyme disease, and we could prove that by gathering data and running a survey through our campus and talking to the students and faculty members. And we think that people's situational awareness make LD cases decrease. So we have 6 different kind of data. We have path type. Some of the walkways are organic, like woods. Some of them are non-organic, like concrete pathways. We have tick data and infected tick data. We have rodents data and susceptible population. Those are the students and faculty members that walk through the walkways. Then we have human risk. We have observed people for 4 days during fall and spring, the people who were walking those walkways. So every time that those students were sitting on the grass or they were wearing shorts, we counted that as a risky event. And then we calculated the percentage of human risk in each walkway. Then the other data set that we are using is the LD cases from Broome County. And then we scaled that number, the first row, and we got the number for LD cases in campus, which is the last row. The reason that we did that is that first we tried to get the LD cases from Health Center of Binghamton University, but the reported number was very few, and we thought that, and we realized that most of the students prefer to go to the hospitals instead of going to the Health Center of the university. So we figured that we have to use the number of LD cases in Broome County and scale that number to Binghamton University campus level. So this is a full simulation model. It took us 2 years to develop the model. It's very difficult to go through that and explain everything. I have created the simplified version of our simulation model. We have 5 different modules. We have tick module, so the tick reproduction of ticks. We have rodents module. Some of the mice become infected, and we have awareness and situational awareness. So the first module, tick module, and rodents module are creating a feedback loop structure here. Then if the awareness and situational awareness increases, it would decrease the behavioral risk among students. If the number of infected ticks increases, it would increase the risk of a pathway, the risk of getting Lyme disease in each walkway. And also if number of infected ticks increases, it will increase the pathway risk. Then we get
just an information question. You said that the tick module and rodent module have some feedback?
Yes.
Oh, I see. That's a two-sided.
Right.
Okay.
And then we get everything in this module, which goes to the probability of Lyme disease transmission in susceptible population that walks through those walkways. Then we try to calibrate the model. We use maximum likelihood estimation. We try to minimize the error between historical data and simulation results. The weight that we are using for this function should be 1 over the standard deviation of error between simulation result and historical data. So we have around 35 parameters in our simulation model. All of them are being calibrated in order to minimize the dysfunction. So this is the simulation results and historical data. As you can see, we got a very good fit, but it's not enough to validate our simulation model. For the next step, we try to build more confidence in our model. I opened the John Sermon book and I did 12 different tests on our simulation model, from sensitivity analysis to boundary adequacy and other tests. For the confidence interval for parameters, I use likelihood ratio method. This feature is available in Vensim. I don't know if you're using Vensim or Stella. I don't know how it works in Stella. In Vensim,
we use Stella.
In Vensim, the payoff values of the optimum parameters value is being gained if we use double weight equal to 1 over standard deviation of errors. Then I keep all the parameters fixed at their optimum value, and except the one that I want to calculate the confidence interval for. Then the payoff function at optimum parameters value minus payoff function at limit of confidence interval should be equal to chi square with alpha value, which is 5%, and 1 degree of freedom, which is almost 3.96. Then I repeat these two steps, step 2 and 3, to get the confidence interval for all the parameters. Here I browse some of them. As you can see, the confidence intervals are very narrow, which shows how strong how rich our historical data is, and how strong our simulation model is, because we have considered so many things in our simulation model, and we could validate the model very well that we could get these confidence intervals for these parameters. Then we started policy analysis. We considered 4 different interventions. These are the common interventions. In the first and the fourth one, we are increasing the awareness and situational awareness from 30% to 60%. In the first one, we do that in a 12-month period. In the last one, we are increasing our efforts to do that in a 6-month period. In the second and the third one, we are decreasing the closing risk, and also we are killing the rodents through each walkways. So when we are comparing the results, if we run the model without adding any intervention for the base run, we get 203 LD cases in 2020. We start the simulation from 2008, and we run to 2020. If we apply the intervention one from 2015, which is the last point that we have historical data, and then we run the simulation model to 2020, we get 124 LD cases and 38% reduction. We get the best results from our intervention 4, which is increasing awareness and situational awareness in a 6-month period. So we got 41% reduction of LD cases. And interestingly is that we don't see a good result by doing the intervention 2 and 3. The other insights that we got against the literature, that researchers are suggesting that the risk of getting Lyme disease in non-organic pathways, such as concrete pathways, is nothing, and we can ignore that. But we realized that in pass 1 and pass 22, we got almost 4 LD cases, which is very significant. Although that number is not significant in compared to organic pathways, but still getting 4 Lyme disease cases is very bad for the campus.
Tire traffic too.
Right. The other insight is that we found that if we increase the public awareness, it doesn't solve the issue. Maybe it's age-related factors, because a student doesn't care about their risky behavior. They always sit on the grasses in summer and fall. Also, they wear shorts. They don't care if they hit the shrubs or not, because even when they hit the shrubs, ticks can crawl on their body and bite them. Also, we found that against the literature, interventions that are targeting closing risk have the least influence on Lyme disease cases reduction. However, if we increase situational awareness, we got the best results. But the cost effectiveness between intervention 1 and 4 should be, we should do cost effectiveness analysis for these 2 interventions, because although we got 41% reduction in LD cases, that number is not that much significant in compared to 38%. So definitely cost effectiveness analysis should be done to see if we increase our efforts to increase the awareness in a 6-month period, it is worth it or not. Our contribution in this essay was that this was the first modeling research that we combined so many data sources together. It's the first system dynamics model that is proposing interventions. We provided the most comprehensive conceptual map, the causal loop diagram. I mean, I didn't show the whole map. I just showed the parts that we simulated. And it's a very innovative interdisciplinary research between industrial engineering and anthropology. Also, we modeled soft variables such as awareness and situational awareness. So I'm going to go to my third stage, which is a combination of system dynamics and GIS mapping. If you have any questions, please ask.
Perhaps. Pause for a second.
I have a few comments, but there's some online we can.
Yeah, I'm going to go check. If you're online and have a question, please speak up. Otherwise, we'll go ahead and start with folks in the room as well. Professor.
Yes, I have a few comments. First of all, you mentioned that the stock and flow diagram, it's very difficult to make sense out of it. And you did a good job in sort of abstracting the aggregate structure of it. Perhaps you can do a similar job on your causal diagram, because as it is, causal diagram is a mental model, and a complex causal diagram is just a good visual, but it's not useful. So my suggestion would be to abstract that causal diagram. So
do you suggest that also for the publication purposes?
Yes, absolutely. Because, well, I've seen publications with that diagram, and they are not useful. That diagram doesn't make any sense, right? So I discourage it. Second thing, you took a while, put a lot of effort into estimating parameters using the maximum likelihood method. I don't know if you have seen the work of Peter Senge.
Bootstrapping method?
No. The work of Peter Senge and George Richardson on the efficacy of using maximum likelihood method to estimate parameters in a feedback system, which is very hugely influenced by multicollinearity errors.
Yes.
And in fact, there are two findings that they have. One is that the parameter set that you get to is not unique, and second, it often has no relationship with the real world. And what they did was they built a model, and then they simulated that model, and from simulations they tried to estimate parameters of that model, and the parameter that they set that they arrived at, first of all, was not unique, and secondly, had no relationship with the original model parameters. So you might want to be aware of the limitations of this statistical method that you've used. Your qualitative findings are interesting, and you should probably build on them a little more. Lastly, there's a lot of work done in the healthcare area. A lot of it is not published because of the proprietary considerations. So the work you're doing is excellent, seems very, very useful, but it's not the first. So that claim probably needs to be toned down. So these are my suggestions.
Right. Thank you so much.
I have a question on a different tack. You work with anthropologists. Briefly, what was that like getting them up to speed on system dynamics and helping them understand what we're doing with all of this interdisciplinary approach?
Right. So first they heard about system dynamics, they approached us, and I had to explain what this methodology is, what were the similar projects that has been done in public health or life sciences, and I had to, I don't know how to say that. I tried so much to convince them that this methodology is very useful if you want to look at these infectious diseases. So I went step by step in showing how similar works for HIV and HPV infection has been done for this system dynamics. And then we started the projects, and when they were seeing how we are working, how we are converting the conceptual map to a simulation model, and when we showed the results, they got very interested in the project and they got more involved. He brought more students to the projects to help us and to give us feedback.
Okay.
Is that what you mean?
Yeah, that's fantastic. Any other questions in the room, folks?
Quick question. I believe in New England, deer ticks are considered a vector for Lyme disease.
Exactly.
Right. So So are you planning to include like a deer population component of your model? Because that's, I mean, in New England at least, I think there's a problem with overpopulation of deer.
Yes.
And it's just sort of exploding the deer tick population.
Yes. And deer is the best reservoir for the ticks because deers would move ticks around the environment and it would increase the pathway risk.
Right.
The thing that the reason that we didn't consider them is that we didn't have data for deer, and also there is an assumption that when ticks bite deers, it would kill their infection, the Lyme disease bacterium in their body. So deers are a source that kills infection in tick's body, and it's not still proven.
Are there any questions out on the online? We've got 6 participants now. Kareem, Chris, Samasi, thanks for joining. Any other questions online, or should we proceed to the second half of the presentation?
I have one question. This is Chris. Thanks. I was curious. At the beginning, you said there's been an increase in ticks, but how do you know that versus that more ticks are being reported?
Because we gather the data through our campus, and based on the data that we gathered, we saw a very significant increase in the number of LD cases and the density of ticks, and that's why I'm saying that.
Okay, so that's measuring the ticks in the area.
Yes.
Got it. Thank you.
Did I hear another question out from the internet?
No, I just want to say I didn't have any questions that Khalid didn't already address, and it's very nice to hear Khalid's voice.
Hello, Kareem. How are you?
Thank
Good.
you.
How are you?
Okay, we'll go ahead and get back to the presentation.
So in this essay, we are combining system dynamics with GIS mapping to study Medicaid access to primary care. I want to acknowledge that we are working with the School of Nursing, Professor et al., and one another PhD student who got graduated last year. She and my advisor, they developed this system dynamics model to study access to care, ACA expansion on and the increase of Medicaid enrollees in the area. Then, so they looked at different aspects of primary care access, including different stages of getting qualified, enrolling in Medicaid, seeking primary care services, and utilizing preventive care. Then I'm using the results of that simulation result to map on the GIS map and look at further to the spatial factors. This is the results that they got. We have Medicaid enrollees in Broome County on the left. We have primary care provider visit rate in Broome County. On the right, as you can see, they could fit the data, and also they show the results to different providers and nurses to validate the model further. And it's a very good model and very huge model. The data sources that I'm using is a system dynamics model results, Medicaid enrollees and primary care visit rate. I'm using the STREP dashboard. They are reporting the number of Medicaid enrollees and primary care providers through New York State. Then I'm geocoding those data in ArcGIS software. Then I get the boundary shape files of Broome County and census tracts from census. Also, I get the FIPS code data along with the insurance and income level of individuals and households from American Fact Finder. So this map shows the Broome County where Binghamton University is located. We have yellow circles, which shows the number of providers in the exact location. We have the number of Medicaid patients in each census tract. So if you don't know about tracts, it's the region that encompasses a population between 1,400 to 1,800 people. So the darker the color, it means the more number of Medicaid enrollees in that tract. I'm going to run the simulation from 2008.
Does it have volume with it?
No.
Okay, good. Never mind.
It starts from 2008 to 2020. The last point of data was 2015. After 2015, we are just running the simulation up to 2020. So as the simulation runs, the number of Medicaid enrollees in each census tract is increasing. However, we have some poor regions, such as Harpersville and Whitney Point, that they have there is no primary care providers in this Harpersville, and also there are just 3 primary care in Whitney Point. These areas are very poor, but they have lack of access to primary care. These guys in Harpersville should travel a long distance to get the providers in here, or there's one more here. However, in this region, which is Westside, it's one of the richest area of the county, and even in the area of Southern Tier, people are very rich, but there are so many primary care providers close to them. Also, here is Binghamton. You see that there are so many Medicaid enrollees in this region, and they have less problems in accessing the primary care providers. Now I'm going to show the primary care visit rate.
What's the spatial scale?
Sorry?
What's the spatial scale? I mean, how many miles is it?
Sorry. It's almost 25 miles. No, 40 miles.
So side to side.
Side to side.
Just a quick comment. I think mapping of these simulations into a spatial area is very interesting. And I don't know how you have done it, but that merits a paper or something.
Yes, sir.
From a methodological perspective.
So this one shows the primary care visit rate. If you remember, the number of Medicaid enrollees in Broome County was increasing, but the number of primary care visit rate was decreasing in Broome County. So I run the model from 2008 to 2020. The color is getting lighter. So it means that the primary care visit rate is decreasing. So if we compare these two maps together, Harpersville has a lot of Medicaid enrollees, but it has the lowest primary care visit rate. And the only reason that we could come up is the lack of access to primary care. In this region, still people have problems. It could be due to the transportation costs or time off from work. We have those issues as well. But the most important issues are for the regions that they have lack of access to primary care, and they are very poor. Then I expanded the work to look at four different counties. We have Broome County, Delaware, Tioga, and Chemont. All of them are in New York State. I ran the model again from 2008 to 2020. The reason that I expanded was that we were thinking maybe Medicaid enrollees who are in Harpersville would access to primary care providers in the next county, but we see that there is no primary care provider practicing in this area. So again, we have the same issue. And then Tioga is the richest county among these four counties based on the median household income. But there are so many primary care providers in this county that if I zoom, you see them? So there are so many primary care providers in this region. Also, the distance is not that much in compared to Broome County scale. So people in here can access to primary care providers that we have 4 of them here. Also, we have 2 of them here. However, Delaware is the widest county and the poorest county, and it has the lowest number of primary care providers. And these guys and up here have a very serious issue in accessing to primary care provider.
Quick question?
Yes.
Do you distinguish between all primary care providers or just those who are
All of them.
accepting Medicaid patients?
Those just accept the Medicaid patients. So they could be nurses, primary care, PA, and MD.
Okay.
And the providers that we are showing on the map are the ones that, based on the data, they had primary care visits from Medicaid enrollees. The way that we have mapped the data on the Broome County is that we are calibrating the number for Medicaid enrollees for the whole county, and then we are distributing that number to the census tracts based on the fraction that we are getting from census. So census is telling us how many Medicaid enrollees are residing in each census tract. And I have that number. I divide that number by the whole number of Medicaid enrollees in the county, and I get a fraction. That fraction from 2013 to 2015 was almost the same. That's one of the assumptions that we have made. So I'm using that fraction for all of those 12 years, from 2008 to 2020. Our next step is getting more data so the fraction is being changed in that 12 years period. But so far, this is the assumptions that we have made. So we found that Medicaid enrollees are increasing, primary care visits rates are decreasing. That's based on the simulation system dynamics model. When we mapped, we realized that maybe lack of access to primary care is the reason. Most of the providers, based on the data and the map, are practicing in urban areas, and we need to establish more primary care settings in high need regions, those regions that I showed you, and also the spatial factors such as healthcare facilities location, distance from patients to providers, and transportation issues are forming the barriers to primary care access. So thank you for your attention. Please ask me any questions if you have.
I've got one on the geospatial, and we'll go online here in a second. Is there anything in your model that's sort of dynamically endogenous that's associated with the map? So you talked about that there's no providers, but is there a way in the model for providers to see that there's none in this area and go open up, or that you force them to open up through like a policy intervention? Because you said that the low visit is because of lack of access. Is there a way in a model to show primary care providers starting hypothetically and therefore visits increasing to sort of prove the theory?
So far, I didn't have the data for that, but our next step is adding providers and each location to our system dynamics model. So if we have 55 census tracts, we would have 55 different system dynamics models for each census tract, and adding the providers into.
So you've got a model per tract?
We have per county.
Okay.
Now I'm expanding that to tract. But it needs the data for each tract, which is not available yet.
So the simulation outcome of the model is mapped into changing the color in those counties.
In those tracts.
I think that's what he has done. So
So we get the number for the whole county, Medicaid enrollees and primary care visit rate.
And how did you do that?
The fraction that I got from census. So census,
The
how I map.
connection between the model and the map.
So I know the number of Medicaid enrollees in Broome County. Then I'm distributing that.
Dynamical change.
Yes.
Yes.
From 2008 to 2020. Then I'm distributing that number throughout the campus, right? How?
Just an additional.
My question was that, is it done from the census data, mapping from the census data, or from the output of your model?
Out of my model.
Output of your model.
Yes.
That's the interesting part.
But the way that I'm distributing that number is based on the fraction of Medicaid enrollees residing in each census tract from census.
So the fraction doesn't change dynamically.
It doesn't change because they are just reporting that fraction from 2013 to 15, and that fraction doesn't change that much. So we made that assumption that fraction was stable from 2008
So
to
the
2020.
model is aggregate, and
Yes, it's aggregate.
it's distributed by that fraction,
Exactly. Yes.
various tracks. And now you're saying that if you had a different model for each
Track.
of the tracks, then you could link the output of those models directly
Yes.
to the shade of color.
Exactly. And now we are negotiating with some organizations to get that data for, but still we don't have that.
Did your data show that there were, in terms of the absolute number of visits, that was declining, or was it the ratio? Because
No, the exact number of visits.
So the absolute number was decreasing. Because I mean, the ratio could get smaller because the denominator is getting bigger.
Yes,
You get more enrollees, even the same number of.
that can be one reason. So that's why we are claiming that it could be due to the lack of access to primary care. You know, it can be because of that. You know, the ratio is getting larger. Yeah.
There's a couple. I'm going to comment. I think there's some really interesting dynamics here that you could probably include on two areas. One is so the care providers themselves, in terms of who accepts Medicaid agents or Medicaid patients, and also this is impacted by what the rate of reimbursements are, or what the absolute level of reimbursement is. Because I mean, I've read about physicians exiting because of declines in reimbursements. So there's the economics of Medicare impacting how the providers behave.
Exactly.
And then there's the question of, how many providers are actually relying on Medicaid income as the primary source. I'm guessing most of those are not, at least in the higher wealth areas, where they're Medicaid. They may take Medicare patients, but that's not the primary source of their income. That's my point.
Right.
So they're concentrated there. I mean, this is the success breeds success problem, right? Where they're serving a higher wealth populace that can afford those services. Yeah. So it promotes more usage of that service because they have that capacity for it. Anyway,
we have two questions from online that I want to make sure we get to. Christine had a question of all of the providers indicated except Medicaid, and I think that gets to something we just discussed. But then you asked about telehealth. Could you explain some more, Christine?
I was just brainstorming, think of ways to improve access to.
If Christine works with the VA, and in the VA you may hear a term, because in the Army they call it white space, areas where soldiers live that services aren't delivered. So the Army delivers a lot of services, and white space is the area those services can't get to. I don't know if the VA has something similar, or that's a concept. I mean, that's obviously kind of what we're talking about.
Even some of the Medicaid enrollees goes to VA health centers, because we don't have data for that.
And then Carlos had a question, are the households mobile between regions? Healthier residents may prefer to leave further away based on rent values. It's a good question. That's a real dynamic territory question.
They would definitely do that, but
yeah, if you had separate models and then you track the flows between them and provide logic for those flows.
Yeah.
Flows between healthcare and
between the various tracks.
So it's almost like if territory has characteristics of that territory, its average rent, its average economy, its average health, then those feed into a population which makes decisions that then itself affects those territory characteristics that then results in changes. That might be very interesting to tie changeable territory characteristics or attributes as part of the model. Do you have any of that or plan to do any of that?
No. I had no idea, and thank you for the feedback. We have to consider that.
Any other questions here? Yeah, go ahead.
So how did you actually map the output of the model into the GIS, into the map? So how is just the mechanic, how is it done? What software did you use?
I use Venison for the system dynamics model, and I use ArcGIS to create the map. I get the number, I have to geocode that number. I get the data for primary care providers, I have to geocode that also to get the altitude and the spatial location of each one at altitude and longitude.
So basically, you first run the model, and then you collect the data, and then you put it into the GIS
Yes,
software. So it's not like done simultaneously. It's not like you run runs and you see the map. It's not like
No, it's not simultaneous.
Okay.
Because we can't connect Vensim to ArcGIS. There is no feature for that.
Okay. So you know angle logic possibly, right? So
I've heard that, but I don't know how to work it.
Any other?
And logic can.
I think they can do it like live.
But you have to do programming. It's not a feature in that.
Any other questions from the field or the internet?
That's like what.
So I got a general question in terms of just the whole the challenge of spatial modeling for system dynamics. Does it make any sense in a problem like this to literally map stock and flow structures to the way distribution, the way populations are laid out geographically? I mean, I've seen this done for like transportation type applications where you're literally laying out stock and flow structures over a transportation network.
So you're saying like stock and flow structure over the map?
Yes.
So you're showing like connections.
Right.
Yeah, I'm interested
I
in
think
there.
it's-
I think in Excel you can do that. I've heard that. I haven't seen.
Yeah.
But
I was just curious if that, I mean, I've seen sort of variations on that in other problems. There's been, as Professor Saeed said, the whole area of sort of spatial modeling for SD is very sort of, formative right now. So, but this might be an area where it'd be interesting to know if you could literally overlay a stock and flow structure of a spatially dynamic problem.
In the insurgency maps or systems I do, I've got different ethnographic populations. So I split them up by ethnography, and then they are distributed within a territory.
Okay.
That then, as people conquer that territory, they get that population, and the population can do dynamic things. But I think I'm also using a kludgy workaround in that what's in each territory is a lookup table. It's a base lookup table based off available information, and then a modifier is applied to it as the dynamics of the model. So if you have
So scaling factor.
well, a scaling factor. So if you have an initial population in Baghdad, but then there's a lot of ethnic cleansing that causes refugees, those refugees are tracked out of Baghdad, but Baghdad will relatively be always the same. It will start and then be affected, but that base start is sort of a lookup table. It's more of a database lookup then, I think, and the attributes applied to it are what change. Does that make sense?
So then the output of the system dynamics model is not transferred to the map in real time, but done after you have the.
I do all mine in charts and tables. I don't have maps unless I hand draw them. So this is a step ahead. But I would think that if you could have a map and have the number in it, like this is, you could have it somehow, even just updating that number, or make it a little more.
Yeah, I mean, you have stocks that represent geographical areas.
It's true. I mean, like not even stocks, maybe like just numbers. Like it's true. Like just numbers change. As you see it.
That's true. It could be
Like so two numbers.
So it'll be interesting to map it like it's done on the spatial.
One of the methods I was proposed, but I didn't end up doing, that is just another, that is called a patchwork model, where those patches, I think, where you're getting to are more of that stock per space, where you're talking models per space, and I did more of a lookup. I think these are, like you said, this is interesting to find something that works.
There's also, I don't know how this is still architect right now, but there's a utility called Spatial Map that links with, I think.
Kareem, do you want to speak on spatial map?
You can talk about
Yeah.
That's what I mean. What Nasser's showing.
Spatial map is it just gives you a 2D grid, and it's built into Stella Architect now, along with our new SVG animation, which lets you do actually any random shape you want.
So if you laid that grid out over a map and you could program in where points of interest were in the grid, you could have the model refer to that point, but it's sort of, you have to stitch it together.
Yeah, so with spatial map, if you want it to wind up to a grid, to a map, you had to do that yourself. You had to arrange it yourself. But with Stella Architect, you can use any arbitrary shape you want, including maps.
Cool. Because I mean, a heat map would be very interesting just for, management type consumers, where you want to see what the evolution of something is over time. So that's where I think that if the newest architect thing that Kareem just mentioned would be very effective as a visual to do heat maps.
Yeah. Yeah, Spatial Map does heat maps, right? And this kind of thing where you animate with maps is something we used to do at UVM with using Tickle a long time ago, 10 years ago.
Yeah. Tickle TK, you mean?
Yes.
So we're going to allow Nasser some final comments. Does anyone have a question before we have any final comments? Any final questions from the field? Go ahead, Nasser, if you have any final comments you wish to share.
Thank you so much.
Was here at noon, or dot at noon, she'll bring this lunch.
Okay.
Well, thank you so much for the feedback.
All right. Well, thanks again, Nasser, for coming. And let's get back to that website real quick. If you want his information, I try to put it up. I'll leave it up here on the screen.
I have an organizational quick question. You're part of, what's the system, what's the group that you're part of? System science, is it?
I'm in the Binghamton University.
Right.
I'm working with Dr. Nassim Sabuchi.
Right. But you mentioned there's the group that you're a part of. Is it a lab or is it a?
This one, System Science and Simulation
That's
Lab.
what I was curious about.
That's the name of our lab.
Okay. So is that within the industrial engineering department,
Yes.
or is it an
Industrial engineering.
interdepartmental?
No, it's in the Industrial and Systems Engineering department.
Okay.
So I'm going to go ahead and stop the recording. That means we can still hang out and chat for a little bit as lunch is going to come, but I'm going to go ahead and stop the recording. Again, thank you everyone for visiting today and joining us. We'll be back on track next week with Wednesday at 1 o'clock for the normal CLM. Thanks a lot.